Dr. Bharat, we are late by 4 minutes.
Sorry, sir. I don't, sir.
Okay. Good morning.
Apologize, sir.
Okay. Today we have a discussion on operative surgery scenario on lateral pancreaticojejunostomy. Our presenter today will be Dr. Anand Bharate. He is a third-year junior resident pursuing DNB course. And our faculty today will be Professor Subhajyoti Ghosh, who is Professor and Head of Surgery at Calcutta Medical College. So, Dr. Ghosh, we can start the discussion. This is just a operative discussion as it goes in PG examination.
Right.
So
good morning, everybody. Lateral
Good morning, sir.
Yeah, good morning. So, lateral pancreaticostomy is a relatively common surgical procedure that is done in our day-to-day practice. Okay. So, you're likely to ask about this operation in your final examination, DNB or MS examination. So, since this is an operation done for chronic pancreatitis, you are supposed to know about chronic pancreatitis in detail, because you will be asked questions obviously on the various aspects of chronic pancreatitis. So let's start with the operative procedures. So you have drawn a card on which it is written usually that lateral pancreaticostomy. So please start your description.
we can ask him just what is the indication at what condition. Not all chronic pancreatitis patients are for surgical treatment. So you can just touch on.
Right. So this is a standard way of presenting your operative steps. So you must know that whether it is lateral pancreatitis or any other operations during the examination. So start with the indication of the patient, indication of the operation. Then if there is any pre-operative management, particularly in case of obstructive jaundice, we need to pre-operative management or prehabilitation nowadays is called as. Then that is also that includes optimization of patient. Then start with the actual operation, patient in the operation theater, position of the patient in the operation table, and other things. So please follow these lines during your presentation in the operative steps. So please start.
Bharate, what are the indications? We have chronic pancreatitis patient. At what point you will decide that patient will be taken up for surgery?
Sir, patient with if I got the patient with dilated main pancreas dilated more than 7 mm and with intractable pain. This will be the
7 mm diameter is quite big diameter, so it is not exactly quantitated as 7 mm. The prime indication for surgery is pain, what you are mentioning.
Sir.
Right.
Diameter more than 7 mm with intractable pain and if any inflammatory mass with the strictures and stenosis of the MPD. These are the indications, sir.
No, in first indication is intractable pain. So what do you mean by intractable pain in chronic pancreatitis? So it is pain in which patient experience both during day and night, is interfering with his or her night sleep or day-to-day work. Right. So that is defined as intractable pain, or in other words, there is also a scoring system which is known by Izbek's scoring system. So according to the scoring system, if the score is more than 7, I guess, so it will be an indication for surgery, right? And other than this, other indications, as you have said, one of the indication is rather I would go sequentially. Indications are obstructive features of chronic pancreatitis, right? So what are the obstructive features the patient can have in chronic pancreatitis?
There may be a biliary or pancreatic duct obstruction.
Biliary obstruction. Pancreatic duct itself, there will be obstruction. So biliary obstruction. So it's a chronic pancreatitis is a chronic fibrosis process. Okay, irreversible changes are there. So it will, as the fibrosis progress, so it will obstruct all the neighboring structures. So one is common bile duct that may give rise to obstructive jaundice. And what are the other neighboring structures that can be involved in chronic pancreatitis? That is
in some cases, there may be gastric outlet obstruction also.
Duodenum.
Duodenum and sir.
Right. So duodenum, right. And also in cases of pseudopancreatic cyst, associated pseudopancreatic cyst over the pancreatic duct, right? And also,
gastric outflow obstruction.
and also in case of pancreatic ascites. Okay, so these are the indications, and some of the rare indications are if there is inflammatory head mass, okay, and where the pancreatic malignancy could not be excluded. Of course, that is the indications for pancreas, duodenum preserving pancreatic head resection or biggest procedures, not exactly in lateral pancreaticojejunostomy. Okay. Now tell me about the preparations, preoperative preparations or prehabilitation.
Sir, preoperative preparation, I will.
We are the patient likely to be diabetic. You understand? Most of the patients are diabetic. He is having pain, and some patient may have exocrine insufficiency. So
endocrine, I will look for the endocrine and exocrine insufficiency test first. For exocrine insufficiency, is there symptom of steatorrhea or not? I will on the clinical history I will take, and fecal elastase 1. These are tests I will do. If for endocrine insufficiency occurs quite at late stage in CCP, if there is more than 90% of the parenchymal cells are hampered, most commonly the patient have diabetes DM type 2. I will evaluate for that. Then patient preparation, patient pre-op investigations, I will do all. And specifically for evaluating chronic calcific pancreatitis case, I will approach with MRCP, CT, and endoscopic ultrasound.
why do you need endoscopic ultrasound?
Sir,
if CT and MRCP corroborate that there is dilated duct, there is no head mass, still you need a EUS to diagnose chronic pancreatitis?
Sir, I have read that is the accurate and gold standard for CCP, chronic pancreatitis diagnosis.
So, you see, when there is inflammatory
Rosenmont criteria and all.
Agreed. But you see, you have to consider that everything comes at a cost. If there is if there is inflammatory head mass, there is confusion with pancreatic malignancy, then comes the role for EUS and EUS guided biopsy. For a straightforward case of chronic pancreatitis with dilated duct, with calculi, EUS is not routine. You can do EUS, that gives a confirmed diagnosis. But at one breath, you should not say CT, MRI, and EUS.
So in a nutshell, we can say for the preparation of the patient for lateral pancreaticojejunostomy, first is to optimize the patient if the patient has diabetes, and secondly, if there is exocrine insufficiency. And these patients are usually chronic analgesic abusers, so there might be some liver function changes. So this has to be taken care and have to be treated beforehand. Then we can proceed to the operation theater with the patient. Now tell us the various steps of the operation.
The patient position will be lying supine flat. ASS and for ASD from mid chest to mid thigh. Operation will be under general anesthesia. There are two types of incision missions, either midline and rooftop incision. Some surgeons prefer. Then first step is there is a wide cauterization of duodenum. Then we enter the lesser sac by incising the lesser omentum and separating the
First is exploration. Try to understand. Once in the peritoneal cavity, first you explore the abdominal cavity, because you have to confirm the diagnosis of pancreatitis and then you exclude other disease. So if you go by chronological order, the first thing you do is the exploration of the abdomen.
Exploration.
Fine. Then cockeration is not first. First is exposure of the pancreas.
Pancreas.
Right.
Okay, sir. We will
How
enter
do you
the
expose the
lesser sac.
pancreas?
We will enter the lesser sac by incising lesser omentum and separating the transverse
Lesser omentum.
greater omentum.
You inside lesser omentum.
No, sir, greater omentum from transverse column.
No, what is the particular the organ is called? Not exactly greater omentum. What is called? That the
ligament is between what?
Gastrocolic ligament.
Yes.
Gastrocolic ligament.
Yes, so that is gastrocolic ligament. Okay, so gastrocolic is a part of the greater omentum that is incised, and you enter into the lesser sac.
Lesser sac.
And then,
As you come towards the head, what do you incise? As you come towards the head, the name changes. It becomes duodenocolic ligament.
Duodenocolic, sir.
You need to expose the whole of the pancreas from head up to the tail.
Up to tail. Then, sir, cockeration, wide cockeration will be done.
Once you expose the head of the pancreas, then comes the how do you cockerize? What is the technique?
Sir, cockeration, then we will trace the pylorus and then continue the duodenum. There is a vascular plane. We will separate in that plane up to the C loop. And then once the pancreatic and lesser sac then pancreas separated from the posterior wall of stomach till the
No. Once you go for cockerization, you have to mention clearly the step. You have to incise the avascular peritoneum at the lateral border of the duodenum. You have to make an incision.
Yes, sir. Incision.
What important structure is there behind the duodenum and the head of the pancreas? You should take care. Once you start cockerizing, you have very important structure lying posteriorly.
Distal common bile duct.
Distal common bile duct? No. As you lift the pancreas with the duodenum, everything goes with that. What is the important structure in the posterior abdominal wall? As you lift the pancreatic head. Yes, what?
Portal vein is there, sir.
Portal vein? How do you get portal vein?
Behind the neck of pancreas.
That is at the neck region. But what sir is asking, when you cockerize, just as you just lift the duodenum, posterior wall of the duodenum, what structure is behind in the posterior abdominal wall? It's a big vessel.
Yeah.
IVC.
Yes.
And aorta.
So it is on the right side, it is the IVC, and to the left of the IVC is the aorta. Right? Aorta. We don't see, but we can palpate the pulsation of the aorta.
Palpate.
We can see IVC, and if you do wide cockeration, then what are other structures that drains into the IVC that can also be seen?
Right renal vein, because that is short also.
Even the right renal vein crosses the aorta and drains in the IVC. Okay, so there the important structure you should be taking care.
Yes, sir.
Fine.
So next, what next? So pancreas is exposed. So what do you do?
Then, if once the pancreas is exposed, there we identify the main pancreatic duct. Either 10 cc we use usually for identification, lateral to the neck of pancreas. Lateral means left side of the neck of pancreas. If there is a frank pancreatic juice is identified, then then pancreatic duct is wide open.
Go step by step. First, how do you identify the pancreatic duct? So you palpate it.
Palpate it.
In chronic pancreatitis, whole of the pancreatic duct is hard. Right?
Hard consistency.
What will be the anatomical location of the pancreatic duct in the neck region, neck or body region? So it will be absolutely in the midline between the superior border and the inferior border. right? So in between the superior and inferior border, you palpate. So if you palpate the duct against the hard pancreas, so it will feel soft. So any soft area that you can palpate in the middle of the uh, anterior surface of the pancreas, so that is likely to be the pancreatic duct, right? So once you find that, then you introduce a needle into the duct, and when you see there is no free pancreatic fluid is coming through the needle, that means you have entered the duct. Okay, then you initially make a small incision over the duct, and once there is free fluid of the pancreatic juice from that area from the duct, then you extend it both proximally and distally. Right. Suppose there is
How far? How far you open the duct?
Okay, how far you open?
Sir, laterally up to the tail of pancreas, on the left side. On the right side, it up to the uh, left border of the head of pancreas.
Left border? Left border means what?
Means up to the head
Left
of
border
pancreas,
is to
sir.
the tail. As you go medially towards the head, don't cut up to the pancreatic groove. You got my point? Don't cut up the pancreatic groove. You stop 1 centimeter medial to that. Why? Why you stop 1 centimeter to that?
There is arcade, anterior
Yes.
supraduodenal artery and posterior arcade is there, sir.
Yes. So you stop 1 centimeter medial to the pancreatic groove. That is the distinction, not the late border of pancreas. Fine. Now the duct is open.
Basically, see, at this point of time, just tell me, basically pancreas is a very vascular organ, right? So can you tell us the blood supply of the pancreas?
Sir, blood supply of the pancreas in the I will start from the head region, head ulcer process. Then I will proceed lateral on the left side. There is a arcade, anterior supraduodenal pancreatic arteries and posterior supraduodenal pancreatic arteries. These arteries are also followed by arcade of veins, anterior suprapancreatic vein and anterior superior pancreatic arteries and posterior superior pancreatic arteries. These are formed by the gastroduodenal artery and downside there these are anastomosis with SMA.
Not SMA.
And
branches from the
SMA gives the inferior pancreatic artery.
Inferior
From
pancreatic
SMA,
artery and
inferior pancreatic and
anterior
from
this anastomosis
gastroduodenal.
form arcade.
Yes. The gastroduodenal divides into
two branches, anterior and posterior superior pancreatic artery, and from SMA inferior anterior and inferior posterior.
So make it simple. The head is supplied by the superior pancreatic artery, which is a branch of the gastroduodenal artery, and the inferior pancreatic artery, which is the first branch of the SMA, superior mesenteric artery. And they form an arcade both anteriorly and posteriorly, anastomose with each other. So that is the head region. And what about the body and tail region?
So in body and tail region is provided direct branches from splenic artery. Sometimes there is a branch of splenic artery called transverse pancreatic artery that supplies the body and tail region.
So is a branch of the main branch from that supply comes from posterior surface of the pancreas, that is called the arteria magnetica pancreatica, right?
Yeah.
Or the transverse posterior pancreatic artery.
Pancreatic artery.
Right. So these are the supply of the pancreas. Now, sometimes we encounter that the pancreas is very vascular and there is wherever you touch, there is bleeding. So tell me some of the techniques or steps to reduce the bleeding during lateral pancreaticojejunostomy.
So when we incise the duct, we first take a full two bites above and below the duct through full thickness parenchyma figure up, and then we incise, sir.
What is the name of the stitches? It's called U stitches. U. So along the head of the pancreas, you take a serial of U stitches, right?
U stitches, huh?
U stitches, some of the vessels will be tied, so there will be less chance of bleeding during lateral pancreaticostomy. And another technique is to tie the gastroduodenal artery, right? If possible, if it is so vascular, then we can also tie the gastroduodenal artery as we do in case of Whipple's operation, right? So that will also reduce the bleeding to some extent. And there is very important steps to assess that. Sometimes when you open the abdomen for lateral pancreaticostomy, the pancreas is rather there is a recent attack of acute pancreatitis, in which case the pancreas is very vascular. So in order to assess this situation preoperatively, we can do estimation of one blood test, right? What is that?
Lipidem, I think.
No.
Estimation of, sir, vascular.
Right. So
Pancreatic.
inflammatory marker.
Oh, sorry, sir.
Okay. So what else? Now, next, the pancreatic duct is open. So what you are going to do that?
Sir, then I will identify for the jejunum.
No, pancreatic duct contains something. Pancreatic duct contains something.
Yeah, sorry, I forgot. Sorry, sir, I forgot. Pancreatic, I will do the sounding of pancreatic duct. There are removal of stones, if any present, and stricture will be dilated. And now proceeding towards anastomosis, I will identify the jejunum.
You don't say that you will dilate the stricture, because in pancreatic ductal anatomy there are stricture and dilatation coming alternately. So once you open the whole duct, you are now laying bare the all narrowed area also. So there is nothing called stricture or plasty here. You are opening the whole pancreatic duct from the tail up to the head. And while doing so, you also go to the stenos part.
Okay, sir.
Some stones are difficult to be delivered. How do you deliver those difficult stones? One is you can catch up with Desjardins. And second is you can irrigate.
Oh, irrigation, sir.
Once you irrigate, with irrigation, some stones also will be coming out. So is it all, or now you add up this operation something else apart from opening the duct? That is a standard operation now. It's not only LPJ. What is added to this operation now?
Sir, head.
Yes.
Head coring is there.
So why do you need to coat the head? What is the principle of this operation?
And lateral pancreaticojejunostomy itself can't stop the disease progress of chronic pancreatitis. Therefore, extensive parenchymal coring is done at the head.
No, the concept is the pacemaker of pancreatic pain is in the head. So once you have decompressed the duct, you are decompressing the duct, the stenos part is taken care of, but the pancreatic pain pacemaker is in the head, in the inflammatory tissue in the head area. So this is a phase operation where you remove this chronic inflamed tissue in the head.
Head also.
So what is the guide that yes, you have done a good amount of head coring? What is there in the head, in the posteriorly?
In other words, what is the
posteriorly
limit? What is the limit of coring?
Yeah.
You cannot go on coring. Finally, you will end up the portal vein.
Yeah.
Right. So
portal and supramesenteric artery, there is portal and formation behind the neck.
No. You see, what is there? What another important structure come from above, joins the pancreatic duct. What is that duct coming from above? That is the
CBD, common bile duct.
yeah. So you stop once you have exposed the common bile duct. The idea is also to decompress the common bile duct. So you need not open the common bile duct. You pour the tissue up to the anterior wall of the common bile duct.
Okay, sir.
Then, so once your coding is, coding and the filleting open of the pancreatic duct is complete. So what is the next step?
The next step is, sir, I will now for anastomosis purpose, I will identify the jejunum at DJ flexure 2 to 20 30 centimeter
How do you
distal
identify
to
the teacher flexure?
the ligament of Fritz.
No, you can't see the. You can see, but you have to identify. How do you identify that it is a DJ flexure?
Sir, I will try the small bowel that will be fixed to the
Yes.
There's one
fixed at one place, that is ligament.
Yes. One.
What vein lies deep to the ligament of Trees? There is a vein which runs deep to the ligament of Trees.
Wait, sir.
That is inferior mesenteric vein. Inferior
IMV.
mesenteric vein. Inferior mesenteric vein.
So these are two important landmark. One is a fixed point. Second is identification of the inferior mesenteric vein. So you know that you are at the this junction, right?
Okay.
Then, so once you
Then
identified
20 to 30 centimeter distal to DJ flexure. I will.
It usually now description is 15 centimeter. You need not go 30 centimeter beyond DJ flexure. The standard point is 15 centimeter DJ flexure.
I will translate the jejunum with GI stapler.
Now, before transaction, you need to divide some of the vessels in the mesentery, taking care that both proximal and distal limb are supplied with a
vascular
adequate vascularity. So you have to divide few of the mesenteric vessels. You have to divide the arcades, the few branches.
Jejunal.
Yeah.
Okay, sir.
So you just transect.
Okay, sir.
Fine.
Then I will mobilize the jejunum. 50 centimeter limb will be taken. Then then through the lateral border, the lateral of the middle colic artery. It's in matlab. I will
You
form
go
the road
anticolic or retrocolic?
retrocolic, sir.
Okay, fine. So you have to
Retrocolic
make a
Rowenweiling
opening in the mesocolon.
mesocolon defect is formed. Defect is found in the Rowenweiling which taken, and at the site of pancreatic duct opening, the two stabites at angle are given to assess the length of the jejunal opening. On the antimesenteric side, the jejunum is incised and open according to length of pancreatic duct opening.
Okay.
Yes, sir.
What next after opening and
Then, sir.
Right.
Then, sir. While the then angle, first of all, angle bites are taken, and then full thickness, including pancreatic duct mucosa, and bite should be taken, and and parenchyma. Full thickness bite should be there, and then posterior anastomosis is done with interrupted suture, and in the same fashion, anterior anastomosis is done after finishing the posterior anastomosis.
So you start saying that I'll do a single layer, full thickness anastomosis between the full thickness wall of the jejunum and the full thickness of the pancreas. So that is one technique. Single layer, interrupted anastomosis. What is the suture material you use?
Sir, PDS.
Okay, so have you seen any operation lateral pancreaticostomy?
I have just first one case, sir. That is operated recently.
Whatever you have seen and you have seen your visiting surgeon is doing, so you can describe that. There's no problem. So and the other techniques, whether if you have seen it is interrupted sutures, fine, you can tell that.
They have done, sir, continuous suture, but
Yeah,
I
so
have read in fissures that intermittent
Hey,
suture is
that
there.
is also
That's why.
acceptable. Yes, even two layer suture is also acceptable.
Mhm.
But in exam, you can describe one technique. That's fine.
Okay, sir.
so after pancreaticojejunostomy, what is the next step?
Sir, then jejunal anastomosis is done, and the defect at the
What distance?
row,
PJ is done. What distance from PJ will do the JJ?
sir, 50 centimeter
35 to 40 centimeter. 40
distance
centimeter is
to,
good enough.
uh,
Yeah. That
and
will
then
be
the defect
what? Anatomically? End to end, side to side, end to side.
side to side, sir.
How can we side to side? You have a open end of the other
No, no,
proximal jejunum. You can do
sir?
side to side, but classically that is end to side JJ.
Okay, sir.
You have a cut end of the proximal jejunum. So
Mhm.
anastomosis is the side of the distal limb.
Right. So after the jejunostomy is completed, next what do you do?
Then, sir, mesocolon defect that I have created for vein, I will secure that ring with interrupted sutures,
One
and
is
now the
mesocolon
drain.
defect, and there is another mesenteric gap between the two loop of the jejunum.
Sir.
In laparoscopy, they don't close it. People doing laparoscopic technique, they don't close these gaps, but standard description is that gap also need to be opposed. Okay. Drain or no drain?
The drain will be placed, sir. In abdominal ADK drain will be placed, or if some surgeon also prefer Jackson Pratt drain also. Surgeon wise preference, sir.
Okay. So and you have closed the abdomen, fine. Now tell us what are the post-operative complications that can occur?
Uh, Sir, first of all, there possibility of post-op infection.
First is infection.
There is
Immediate post-op. Immediate post-op. We talked
every
about so
post-op,
much
sir.
of vascularity.
Infection, hemorrhage.
First
So
is
one is
hemorrhage.
bleeding, right? So hemorrhage or bleeding.
Yeah.
So I mean, bleeding from where? You have drain. Would you put up the Riles tube in this patient?
Yes, sir.
Yes. So there may be bleeding. So what are the sources of bleed? I mean, bleed can occur from the Riles tube or it can occur from the drain, right? So if it occurs from the Riles tube, so what will be your interpretation? And it occurs through the drain, abdominal drain. So what will be your interpretation?
Sir, about drain, obviously there is a cross vascular structure. Is any vascular structure is injured? Rise tube, sir, I have no idea, little or no idea.
So if it is through the Riles tube, that means it's a bleeding from the luminal surfaces, right? You have done the anastomosis.
Yes, sir.
If there is bleeding from the anastomosis, so it will come through the lumen of the intestine, maybe backflow into the stomach, and then it will come through the Riles tube. So it will be a luminal bleeding. And if it comes to the abdominal drain, that means it's an extraluminal bleeding, right? You have pauperized the duodenum and so many structures you have dissected, okay? So maybe there will be a bleeding from any of these extraluminal sites, right? So accordingly, you will have to treat the patient. Okay, so if it is a suppose it is a bleeding through the Riles tube. Okay, so what are the steps you are going to take?
Yes, sir.
Patient BP is 80/50. Blood pressure 80/50,
First,
blood in Rayleigh tube. So you are in the ward in the evening. What steps you should take?
I have to first of all resuscitate the patient.
Yes.
I will do resuscitation and then, sir, re-exploration.
Re-exploration, always.
No, sir, depend on the bleeding quantity. I will do resuscitation first
Yes.
and
So
check
resuscitation
for
means
PTNR and all the things.
you arrange for blood. If the
Blood,
patient
sir.
is having hypotension, so much of bleed in the Rayleigh tube, so resuscitation will also involve, apart from giving crystalloid, you should give the patient blood transfusion. You can
Yes,
give
sir.
the patient some non-specific tranexamic acid also, because you don't know the source of bleeding. Minor capillary use can be controlled with tranexamic acid also. So how do you decide re-exploration? All patients will not go for re-exploration.
So would you like to consider upper GI endoscopy in this patient?
Yeah, sir. Luminal bleeding is there.
Why? What will be the
Okay.
idea? So the upper GI endoscopy, you cannot reach the anastomotic site.
No, sir.
So at least you know whether it is from the stomach or is beyond the stomach. Number one. Number two, there may be stress ulceration, right? Patient may have associated chronic duodenal ulcer. So those other things can also bleed. So you'll have to exclude that, right? Before you decide that yes, this could be from the anastomotic site. Bleeding could be from the anastomotic site. Okay. Right. So suppose it's a torrential bleeding. I mean, say you are having say 1 to 1.5 liters of fresh blood through the Rayleigh tube, right? So before re-exploration, you do you have any other?
Here in a very good setup.
Yes.
We have all backup. Anything else can be done at this stage, short of going for re-exploration?
Sir, endoscopic ligation.
No, endoscopy, you are not seeing the bleed. It's not a duodenal ulcer bleed. It's a bleed which is maybe partly intradominal or they're coming to the drain. But bleed is too much. What else can be done in the immediate post-op period? You're in a very good setup. All backup is there. Apart from
Arterial
endoscopy,
embolization.
how?
Arterial embolization.
Again,
Radiological.
embolization cannot be done straight away. What has to be done fast? Before embolization?
You'll have to identify the source of bleeding. Then only you can go for arterial embolization.
CT angiography.
Yes.
Yes.
So you can ask for a CT angiography, where you can localize, because you say patient is having active bleeding. So if you do CT angio, you can localize the active bleed, and if you have a good intervention radiologist, he may embolize. So short of surgical intervention, you can attempt for angioembolization.
Non-invasive.
This is a
Right.
patient who is diabetic. How do you write the fluid direction for this patient? He's a diabetic patient, and now you have done surgery for 3 hours. Now you are writing the fluid direction for this patient. Tell me the fluid direction. This is your patient. How do you decide how much fluid he should receive, what quantity of fluid, and what type of fluid he should get? He is diabetic, controlled diabetic.
Ringer solution and normal saline I will prefer, sir.
Wow. You have not read swords regarding post-op fluid therapy. You will pump the patient whole day with ringer solution and normal saline. That is a wrong concept. You read swords. How do you plan post-op fluid therapy? Be the patient diabetic, be he is not diabetic. All patient need some amount of dextrose in the immediate post-op period.
Usually, sir, other patient I prefer NSS to
No, no,
D5.
no, 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 no. That is what I'm saying. That is a wrong concept. If you are pumping the patient whole day with how much fluid to give? Patient underwent pancreaticojejunostomy. There is some dissection. So there will be some amount of third space loss also in this patient. So what might be your, maybe patient was 60 kg weight and now you are charting fluid. What may be the average fluid required for this patient? How do you calculate the volume?
For 60
You
kg
just
patient, sir.
cannot, you see, there is nothing empirical right about 1:1 or total this. How do you at least estimate? There is a way of estimation of this patient. Number one is maintenance fluid, and number is two is he may have some containing loss in the form of you have rice tube, you have drain. So take into consideration those also.
Sir,
Okay, that will be a separate discussion.
approximately 100 ml
We
per
will discuss
hour.
separately. We will discuss this. It's a wrong concept to say RL and NS combination. You are pumping too much sodium into this patient. A 60 kg man requires only 100 to 120 millimole of sodium in 24 hours. If you are giving him 2 liters of normal saline, you are pumping him 300 millimole of sodium, which is detrimental, which may be detrimental for your anastomosis. There will be interstitial edema. So read SWARJ regarding postoperative fluid therapy. That we will discuss someday. Okay, Dr. Ghosh.
So another complication, although rare, if after lateral pancreaticostomy is pancreatic leak, right? Usually any operation on the pancreas, we always afraid of the pancreatic leak or pancreatic fistula. So why it is relatively uncommon in case of lateral pancreaticostomy in a case of chronic pancreatitis?
In Whipple's, it is a more serious problem than in chronic pancreatitis. Why? We don't give octreotide even prophylactically for a patient of chronic pancreatitis. Why?
Sir, about octreotide, I have read that
No,
it
we are
is
not
the
giving.
institution.
Dr. Ghosh has asked you the risk of pancreatic leak, pancreatic fistula is much less in a patient who has an LPG versus a patient underwent surgery for trauma or Whipple's. Why it is
Sir,
less?
it is a chronic inflammatory process. There is already atrophy of pancreatic
Yes.
parenchyma.
Yeah.
So it is almost a disease pancreas, so the pancreatic secretion is less, right? Whereas in
Less.
pancreatic trauma is a more or less normal pancreas, and that there is normal pancreatic secretions, right? So because the secretion is less, so chance of pancreatic fistula, pancreatic leak is less. Okay. And so these are the immediate postoperative complications that may occur. So what are the long-term complications in this patient? And what is the number of patient or percentage of patient that can have pain relief? We have done the operation mainly to relieve the pain, right? So what is the
Yes, sir.
percentage of patient that usually pain relief occurs after this operation?
Exactly, sir.
Sorry?
Some patient may have persistent pain. So what is the percentage of patient who may have persistent pain?
40% patients, sir. Approx, I'm not able to collect the paper. Somewhere to 40%.
So usually 70 to 80% patient gets pain relief and rest 20% patient does not get relief, okay, after this operation. And even after 5 years, so this of this 70 to 80%, again the 50% of patient may have recurrence of pain, okay, because it's a chronic and progressive inflammatory process. Now suppose this patient after say 5 years come back with a pain, again the same type of pancreatic pain. So what are the options you have now? How you are going to treat this patient?
Sir,
Do you understand my question? So after LPJ,
sir, after 5 years, if patient come with recurrent pain.
with the pain, right?
Yeah.
First, you'll have to evaluate whether it is a pancreatic pain or non-pancreatic pain, right? If it is a non-pancreatic pain, so treat accordingly. So if it is a pancreatic pain, then first we'll treat with the pancreatic supplement whether he is getting adequate pancreatic enzymatic supplement or not. Okay, so that has to be ascertained. Then we can treat with the analgesics as a step up fashions, as we all know. So if it works, fine. If it does not work, then what are the options we have? Any radiological intervention, or patient may be sent to the pain clinic and they will do what?
Sorry, sir.
You've not heard?
Nerve block, any kind of nerve block?
Sir, I have read in Fishers that celiac
Yes.
ganglia block they give with 50% ethanol.
So celiac plexus block. Hey, don't say during exam, don't say I've read in Fisher, I've read in Swartz, right? So we are supposed to acquire the knowledge
Sir,
of
just
books, right?
actually, I have not seen, sir, so much patient of LPJ.
Doesn't matter.
Just what I have read is
No,
theoretical,
there are
sir.
some ways, na? You have to read that. What will be the options for pain relief?
Right. You have to attend these classes. You have to attend various seminars, conferences from these sources. You will have to acquire knowledge, not only just from the books. Right. So celiac plexus block is another option which usually can be given in a patient with recurrent pain. But celiac plexus block unfortunately works for maximum 3 to 6 months. Right. After that, again, the patient may have recurrence of pain. So in such a situation, what do you do? Pain recurs after celiac plexus block. So any further surgical intervention?
Very difficult surgery. Yeah.
As Sir has already pointed out, the head is the pacemaker of all these things. So usually pain starts in the head region because head is the region where all the embryological fusion occurs. Okay, so that is the reasons most of the diseases of the pancreas starts in the head, right? See, head of the pancreas is a common, then chronic pancreatitis pain starts here. Okay, so we can resect the head. What is the name of the operation? I've already mentioned once. LPJ is done and patient is having recurrence of pain not subsiding with the other conservative management, then we can take up this patient for
duodenum preserving pancreatic head resection.
so that is biggest operation. Very good.
Biggest.
So we can try that. Okay, and even if that does not work, then what is the last option?
Last option is total pancreatectomy.
Right. So sometimes
it's a very morbid procedure, very difficult. Okay.
So that is the last resort, and it is I've not experienced, again, like you said, written in the book, that even after total pancreatectomy, patient may not have diabetes, right? So okay.
Thank you. Thank you,
Okay.
Dr.
Okay.
Yeah. Thank you, Anand. Thank you.
Thank you.
Thank you, everybody.